Oh, we're ready.
Yeah, we're ready.
You introduce.
Hey everyone, we're back. So Corey's friend sent her an email with some questions. So we were just about to go into a big spiel into the workroom, like, to answer all these questions. And we're like, let's record it so everyone can hear. So I actually haven't even really heard any of these questions. Leah heard a little bit, and so Corey's gonna read the email, and we're going to discuss it.
All right, so we have a kiddo, 10 months old. He's showing significant oral defensiveness during feeding, behavioral problems. The only thing he is eating is he's drinking a bottle. He has to be either rocked or sitting in someone's lap. He's defensive to the Highchair, and he's not taking purees. And they've tried, flattening the tongue with the spoon, and he just screams and screams during that.
All right, so my question immediately to that was, what's the medical history like? Any history of reflux or constipation, any type of GI issues, and have they assessed the kiddo for a tongue tie? And so she followed up with that, and what she said?
So he did have a history of a tongue tie, but it was surgically repaired. He had a seizure right after birth, so they don't know if that ties into it. And he has problems with his face being touched, so they don't know if it's sensory related.
Okay, so we're going to go into this answer with out knowing if there's any GI issues. Our first thing for sure would be to rule out any type of GI issues. Did the kiddo have significant history of reflux? Is it being treated? How are bowel movements? All of that kind of stuff. Because, yes, we can work on decreasing the oral defensiveness, and yes, we can work on the oral motor skills, but the medical side of it needs to be managed. So we're going to just assume that kiddo's being managed with reflux and that there is no constipation issues with our answers moving forward.
I would kind of like to know, when was the tongue revised? Was there any follow-up care?
Who revised it? What kind of revision?
Yeah, who revised it? Was it laser? Did they go to an ENT and have it surgically repaired? And then what was bottle feeding like after that? Did they bottle feed? Did they nurse? What was the feeding like after that? Because when did a problem really occur?
Right. And he's still having a problem getting a good latch. It takes a few sucks before he maintains a latch.
And that's what made me ask about the tongue to begin
tie.
with. If there was a tongue tie, because why is he having a difficult time latching to the bottle? Because it is interesting to know too that a lot of kiddos that have tongue ties, like if it's a posterior tongue tie, which we do see a lot of now, those babies will have issues nursing, but they do tend to latch to the bottle fine. So this right here, I had two kiddos, my two older ones both have posterior tongue ties. We're not able to nurse, however, took a bottle fine. This kiddo right here, the issue that he's not latching to a bottle, well, that is concerning. And we also
with the history of the seizure, what was affected, maybe there's some weakness, which is what it seemed like. There's definitely, the strength was affected, probably jaw weakness, possibly why he's not getting a good latch.
So we would look at the oral motor side of it for sure, just do a complete oral motor assessment and see what the strength and the tone and everything looks like. And then there's a lot of sensory play-based stuff. She said that she thinks it's kind of sensory related as well, so I don't know if there's any other type of sensory issues. We'd also look at bringing
tactile defensiveness, are they sensory seeking? Are they,
He sounds like an avoider. It's what it sounds like. So then a lot of food play. You have a kiddo like this right now that's super aversive, won't even sit in the high chair. The kiddo you saw, you're seeing this afternoon. So talk to her a little bit about the play type stuff that you do prior to.
I feel like I have so many more questions about this kid that needs to be asked. What happened when they introduced purees? What happened? Why is there an aversion now? It said that, I don't think you read this, but you guys said only accept purees when forced. So why is there forcing going on? And is that what's even made this aversion so big, So I want to know how foods were implemented and all that. But I guess without all these questions being answered, if I had a kid who was defensive, only accepting a bottle, not accepting anything else, like how would I go about this?
And keep in mind that she says that he'll only accept the bottle when he's being held and or rocked. So when you start some of the oral, like when you're trying to decrease some of the oral sensitivity, that would be the perfect time to do it, is when he is in a more comforted type stage. So after he's taken the bottle, or before he's taken the bottle, when he's sitting on mom's lap and they're rocking and singing songs, she can start doing some like facial massages where it's not related to sitting in
So he's
a
more
high chair.
comfortable.
Absolutely, and just working towards, in a safe manner, decreasing oral aversiveness. So, we're rubbing on the cheeks and we're doing little tapping, and there's a lot of research behind doing bilateral stuff. So not just going in and doing something on one side. Our OT, she had told me a long time ago that there's research in the field about it. When you do it bilaterally, it confuses the system. So you're typically able to get kids to tolerate better, and I have found that to be successful. But keeping in mind, we don't know what he's like Julianne said, we don't know what he's like in the rest of his body. So before you even go to the face, we know that that's an area that is not good for him. So let's start moving up their legs. We're doing the little massages and we always pair it with counting, so they know that there's an end to it. So 1, 2, 3, immediate reward. Way to go, buddy. Going to the arms, doing deep pressure, like 1, 2, 3. I have had kids before that right there was enough to make them vomit.
Yeah.
So if they're vomiting here or they're vomiting here, they're not tolerating this.
Yeah.
So making your way up, and then if he tolerates all of that, fine, then we can start with the deep pressure. And again, this is why OT is so important to have involved, because does this kid like deep pressure? Does he prefer soft touch? We don't know. The soft touch may make him overstimulated.
Yeah, people think sometimes that when they touch a kid softly that it's less stimulating, but it's actually more stimulating. It's more like a tickle. So that deep pressure is
I don't like
better. So just like she said, starting with stimulation, if they can tolerate a count of 3 or just a count of 1, and then usually, like she said, immediate reinforcement after that, and then working your way up from a count of 3 to a count of 5 to a count of 10, and then singing a song.
Yes.
So wherever a kid is, and what I like about that is that it kind of gives a kid a timeline of how long can I tolerate this for, because we can tolerate anything for a short amount of time. So if they know, okay, when Twinkle Twinkle Little Star is over, then I'm done. And you'll find that kids will tolerate the stimulation a lot more.
When they know there's an end.
Yeah, when they know there's an end. And then also singing has been shown, research shows that it calms and helps regulate kids and babies. So not only is it serving as a verbal cue, but also, helping regulate and calm them so that they can tolerate, and reinforcement, distraction. You can use, toys, things like that.
And we, a lot of times we'll do, so, a lot of, like the songs, like don't put it on your phone immediately and let the kid watch it, or the TV. Just sing at first, and then maybe that might not be enough, so then we go to the toys, or then we go to the the iPads or stuff. But we want to make sure that we're doing the most functional thing at first. He can sit in mom's lap anywhere they're at. We might not always have a phone, we may not always have a toy or something, but once he's tolerating it, then we get to the face, and once he's tolerating the face and letting you get inside, what's toothbrushing like? We don't know that. So we got to get those kind of things first. Once we get past the oral defensiveness, then we can start working with food. So, and a lot of times we've had kids that you literally, we're just trying to get them to sit. I've had to take the tray off of a high chair and put the tray on the floor where we're playing, and get the kid to just sit with the tray in front of them. It's been that bad that they just, when you see a high chair, they go into defensive mode. And so you play down here with food, and just, make it more of a fun type thing. Reading books about food, reading, stuff like that.
You have to build that relationship of trust. And I feel like sometimes we don't look at how we're coming to these kids with food and trying to get them to eat. If someone was shoveling stuff into your face, and even as an adult, someone comes to you with something, here, try this. You're like, whoa, wait a second, what is that? Like, you want to see it, you want to smell it, you want to take it all in first before you're willing to taste it. And so if you come at a kid, they're not even seeing what you have, you shove something in their mouth and they're like, oh, what is this?
Yeah.
and they already have issues going on, you're gonna create an aversion.
Yeah.
And so there has to be trust between that, that caregiver and that child for them to let you put anything in their mouth, even if it is just an empty spoon. And so that's what we work on, just things that are not threatening, an empty spoon, our finger. We want to build that relationship of trust before we even get to the food.
And you don't want them to have an aversion to you as a clinician when you walk into their home.
That's the first thing. Or just to the mommy.
Yeah.
I mean, they're the ones
It's
there all the
anxiety.
time. Yeah. So I mean, we're hearing the description as force, and I'm sure they're not forcing, but I mean, we hear that a lot, and a lot from the parents, and it's like, luckily this baby is being sustained by the bottle right now. So we can take this time and really let him learn about him or her, I can't remember, but let them learn about feeding, and that it can be fun, and that everything doesn't have to be, painful. When you have an orally defensive kiddo like that, I'm sure there's a history of reflux. It's very rarely that we don't have kiddos this age that don't have something going on because, they've had a negative experience. And so, Julianne, she's really great about reminding me a lot of times too, is that even starting with just the dry spoon. And I do start with the dry spoon, but then I start dipping into like puree or something, but even keeping it further back and dipping it into the milk or dipping it into, whatever they're already accepting, and then slowly introducing, bigger amounts, like, a dip. And then if it's too much, they start gagging, then we go back down to the dip.
To where they were successful.
Or back to the legs.
Yeah, or back
wherever you have to go to get them
So with that patient that I'm seeing right now, he's really hyper aversive, and I'm working with mom on teaching her these behavioral techniques, because unfortunately these kids get to a point to where you have to use these behavioral strategies rather than really cue-based feeding, because we're past that point. They already have an aversion and they're not going to let anything near them. So we can do play-based and introduce all that, but that doesn't help us when they're throwing a fit when they get in the high chair or they completely reject a spoon.
And they're in meltdown.
Yeah.
And they're not regulated, so they're not gonna, nothing we're doing.
Effective.
Absolutely.
So providing a dry spoon and then immediate reinforcement for accepting it. If they don't let it in their mouth, then touching it to their lips and then providing the immediate reinforcement for that. So teaching the parents kind of the ups and downs of these behavioral strategies and making it something that's easy for them to accept. We don't want to go in with a big old spoonful and say, eat this, and then what's going to happen?
Yeah.
So we give them something easy, whether it's my finger to their lips, the spoon to their lips, or something, and providing that reinforcement. And a lot of times you can go very quickly in a session from touching to their lips to easily accepting a dry spoon, because they realize that, hey, it's not that bad. It's not that bad. There's nothing threatening about a spoon. At that point, you're building that trust. And then once you get them accepting, they're easily accepting, you're providing reinforcement, then you can start putting stuff on it, but not a big old spoonful.
No,
We're going to try a little taste, or maybe just dip it in water, It's just going to be a small amount. And at no point are we like trying to sneak it in there.
No.
We want to tell them, all right, this is a hard bite, we're going to have a taste. And that's
a big bite.
Yeah.
This is our small bites, and now we're gonna try. Anytime you change it, they have to be aware of what's going
that's
on.
what I'm really working with this mom, and she's doing amazing. Like I saw her yesterday, and I was just like so proud of her using the verbal cues. Like we're not just coming to you with a spoon. We provide so many verbal cues and then decreasing those. So up into, all right, time for a bite. Ready? 1, 2, 3. The kid's ready, feet opens. And then 1, 2, 3 every time. Ready, bite. 1, 2, 3. And maybe we'll get to ready, bite. 1, 2, accept. And then ready, 1, accept. Or then ready, bite. It's a slow decrease, but you can't just go full force. Here's a spoonful of food. Eat it. It takes a while, and I guess that's hard for parents sometimes, because they come in and they want it fixed.
And
You're the
also,
professional, fix it, but they didn't get here overnight.
No, and also with that, keeping in mind that, you know, we may have a kid that is eating super great 15 minutes through the meal, and then at some point something happens and it's too much, and they've been accepting. We don't even have to prompt them. Like, they see the spoonful and they're overly excited to take a bite. You saw the little one we saw today. The first couple
So
spoonfuls,
excited.
he was so excited, and then halfway through something happened. So we have to step back, and then we have to go back until he's successful, and then slowly work it back up.
Go back and find that point of success. And he may have been accepting full spoonfuls, and now you're back to touching my finger on the lip, or even just tolerating sitting in the seat, you know, and then working your way back up again.
And I think you do a really great job of this. Making sure that we're only reinforcing the behaviors we want to see. And this is very difficult for parents. I saw you in your session a couple weeks ago where, you know, mom's like, well, what should I do? And you're like, we just turn. Like, we have to be able to make sure we're training parents on that, is that if he's having a tantrum and they're having a meltdown, we're turning away. And as soon as they stop, we're reinforcing that. Because if you're like, stop throwing a fit, stop, we're giving
that attention. Our kids will do this and they'll lean towards their mom and they're waiting, and mom will give the hand and they're like, take me out. And you're ruining the session at that point.
You're in the session, then they learn that that's what can happen. If they're throwing food on the ground and we're like, oh, okay, we're done. Well, now they've learned that that's being rewarded. Yes, absolutely.
My big thing, what I always tell parents, because this is so hard using behavioral strategies for feeding with these kids, is that it's always going to get worse before it gets better. And it's so hard sometimes for parents to get that, you know, if your kid is crying and you give them attention, then they start crying and you're ignoring them. And then what happens? They're going to go, you know, they're going to go again even harder. They're going to start screaming, and then you're not paying them attention. What's going to happen? They're going to throw themselves on the floor. They're going to start spitting. They're going to do whatever they can to get your attention. And at any point you give them attention, they learn that's where I need to go. So if you give them attention at any point in that fit, next time they're not going to start by crying. They're going to start by spitting. They're going to start by throwing themselves on the floor. So the point is to really not give them that attention until they're acting the way they're supposed to, whether it's being calm or whatever. So if that means they throw a fit in that chair until that moment that they're calm, providing that reinforcement and then letting them out. You never want to end your session with them throwing their fit. You know, you never want to end a feeding or anything with them throwing a fit, because then they learn, if I do this, then I get out of it. And so ending it with them quiet, happy in the chair, and then finally we're done. You don't have to push any more feeding after that. We just want you tolerating being in the seat, because that's your point of success at that point.
And we have to keep in mind that, like she said, this takes time. And so we have to give kids time to be successful at a certain point before we're pushing more on them. So, you know, like this kiddo right here, I mean, he's probably not even ready to be put in a high chair yet.
That's what I was going to ask. So would you suggest, you know, he starts in mom's lap and you present a dry spoon, or you work up to the oral stimulation in the lap, right?
Before we're presenting the spoon, we want to make sure that, because think about with babies, we like playing with them, kids are doing all that kind of, we don't even know, has he ever brought his hands to his mouth? Does he even allow himself to do those things? And if he's not, then we have to get past that first. So he's taken the bottle, but even with the bottle, he's not taking it without issue. So we have to figure out what's going on there.
Why isn't he able to regulate himself during feeding?
And so we figure out, we're going to have to figure all that out, but we're saying this is a kid that is regulated and is on reflex meds and all the medical stuff is taken care of. And so then we sit him in the lap and we start, like we were talking about, work your way from the bottom up, and the hands and the face, and once he's fine with all this, then we start doing dipped spoons in something he is accepting, like the formula or the breast milk. Dip it in and then, you know, work your way that way. But just because he accepted that today, we still have to give him time to get used to that. And then, you know, we start doing the dip spoons and the puree, and we have to give them a period of time to be successful with that. I find that with parents a lot, that they're like, okay, well, they're doing it, let's move on. And it's like, well, they should be taking this, so we're making our progress, but we have to give them time to practice and be successful.
Because what would a typically developing baby, like, you wouldn't expect them to go puree 1 second and then something. They take their time, like over a 6-month period to get to that point.
I didn't think about that. And then would you also suggest that they do sensory play in the high chair that has nothing
Yes.
to do with food?
Yes.
Suggest that to
Or
mom?
even with food,
With
just
food,
taking
playing with their
just
food,
taking
yeah.
the pressure away from eat.
If
Yeah.
he'll be able to tolerate, food on his plate,
Yes,
Cheerios,
yes.
playing with
Play,
it
yeah,
outside.
babies.
Yeah, put them in
Okay.
trucks or put them in the cup and anything they can put in and dump out.
Paint with them,
Yeah.
draw around, yeah, absolutely. A lot of sensory play. That's all kids though. We are all,
Yeah.
we tell parents all the time, like, take their clothes off if you don't want the clothes to get messy. We are here to get messy. We are typically from head to toe covered in food, so.
Yeah, I think about with my baby how many opportunities throughout the day I gave her to just get any oral stimulation, whether she was doing it herself or I was doing it, or I gave her things to like play with that were just completely separate. And that's with a typically developing baby and a baby that has no aversion.
Yeah.
So you think about all the opportunities, that a parent has to present food in a way that's not, that's not going to be aversive and that's more playful and, where they're not going to be so stressed. There's so many opportunities where they could be doing this. A lot of times I sit my daughter on the floor with a box full of cereal and some spoons and let her go at it. Like, it's great sensory
It's gonna
play.
be messy, but
Yeah,
it'll
it
be
is.
worth
And that's
it.
why I have dogs.
Yeah. All right, so when we get more information, we can give more information. But
Yeah.
with what we have, and assuming that we will always, always, always rule out the medical side of things. We would never jump into any of this without knowing what was going on medically.
Right.
But with this case, we don't know all of that, so we're just going to assume the kid was being medically managed. But it's a little bit on what we would do for that.
Well, thank you for
You're
answering those
welcome.
questions.
Have a great day, guys.